Thank you, Dr. Srinath and Dr. Rajadare, for this opportunity given to me to share some of my thoughts on a very important but an often neglected area in the emergency department: must know etiquette and communication skills in the emergency department. I just want to start my talk with a quote. To most physicians, my illness is a routine incident in their rounds, while for me, it is a crisis of my life. I would feel better if I had a doctor who at least perceived this incongruity. Obviously, when a patient comes into the emergency department, however minor or major the problem is, the patient is often very worried about what's going to happen to him or her, about the future, how many days the person needs to spend in the hospital, what is the diagnosis. It is not only the patient, but the patient's attenders too, who are very worried about what is going to happen to the person. A busy emergency department is synonymous with chaos, confusion, and unrest. Obviously, the attention of the emergency physician remains focused only on the patient in front of him or her, and they do the best that we can do for that person. The emergency physician seldom finds time to talk to the patient and their families. Not the fault of the emergency physician, but the work is such that the person is so busy seeing patient after patient, taking care of very sick patients, resuscitating, that he or she does not find enough time to communicate either with the patient or with the families. So what are the problems that we actually face in the emergency department? High volume of critical patients. There's always a perpetual shortage of trained staff, especially in our country where our specialty is still evolving. And not just emergency physicians, but trained nurses, technicians, ambulance services. All these are evolving and would definitely take a few more years for us to take care of this shortage. Obviously, as the person gets older or becomes more senior, their availability at odd hours is less. Inadequate facilities at primary and secondary levels. We have excellent tertiary care hospitals, especially in the city, but further away, we are not able to replicate the same kind of facilities. And all this will definitely make it a very challenging area to provide adequate communication on a consistent basis. Patients are often acutely sick, leaving little time for a detailed explanation. And obviously, the situation of the patient is rapidly changing. For example, a person who comes with shortness of breath, you might give oxygen to the patient and find that the patient's saturation is improving. You go talk to the patient, and suddenly you find that the patient becomes more breathless or hypoxic or is an altered sensorium now, would require intubation. So it's actually changing all the time. So more frequent monitoring and interventions may be necessary. So it's probably a little difficult for you to communicate to the patient's relatives whenever you want to do another intervention. And obviously, the diagnosis is often not clear during the initial assessment, because as you encounter a problem, you're actually intervening, but you're not actually having time to do a complete examination or wait for reports before you actually speak to the patient's attenders and to the patient regarding their problem. Patients and their accompanying family members are not surprisingly extremely anxious, especially when it's a child. And they are extremely anxious about what is wrong with the child. So it's very good to communicate with them frequently, especially if you're dealing with a child. And the atmosphere is often so charged, and it's, because the stakes are very high, either for the patient or for the patient's relatives, because the patient wants immediate care and wants to get okay as soon as possible and carry on with their lives. So if the communication is not very good, reports of violence and skirmishes are common occurrences, especially in our country, and reported quite frequently in the papers. And bearing the brunt of it are the doctors and nurses and technicians who are actually working in the emergency department. Studies have shown that 98% of the attendants accompanying patients to the emergency department have some form of stress. Obviously, lack of communication leads to patient dissatisfaction, eventually leading to aggression, which is either verbal or physical. So the only way for us to reduce the patient dissatisfaction or aggression from the patients or the patient's relatives is to talk to them more frequently and let them know what is the problem with the patient on the initial examination and what kind of treatment is being given to them. Surprisingly, a study showed that 81.7% of surgical residents did not receive any training in communication skills. And not so surprising, 32% of the residents spent less than 1 minute counseling attenders for surgery. Everybody is in a hurry. They say this patient is having an appendicitis, needs surgery. And you have to spend more time with the patient and the patient attenders actually talking to them, explaining to them what is the problem and what kind of surgery, how many days the person needs to be there in the hospital, what are the complications with the surgery. So all these things are very important, and spending less than 1 minute is not going to serve its purpose. Most complaints by the public about ED doctors deal not with the critical competency of the person, but always with communication. Yes, incompetency may be there, but that is not a major problem. Most complaints are because the patient's attenders do not know what is actually happening. And several malpractice allegations arise from communication errors. The patient is unaware that such a procedure is being done on the patient. So it's very important that you get the proper consent before you actually do a procedure on the patient, and tell them what is the reason why you are actually doing this. This is one of the things that you can use to remember. Always AIDET, where A, you acknowledge the patient. It's very important that you introduce yourself and acknowledge that the patient is there. Introduce yourself either as a resident or as a consultant looking after the shift, and tell them that you will take care of all issues that are there and you can always contact them. Okay? And always tell the patient the duration of stay in the emergency department. Everybody feels that the stay should be minimum in the emergency department, fair enough, and then go into the hospital. But always tell them it may take 2 or 3 hours for you to get the labs, or in case some procedures that need to be done in the emergency department. Always overestimate the time so that the patient is not very unhappy about it. Always show empathy towards the patient. Explain properly as to what is happening to the patient and what is next that is expected. And always thank the patient for having chosen the service of your hospital and wish them very well. What are the common weaknesses that actually happen in a doctor-patient consultations? You use medical jargon which the patient may not understand. The person may be educated, but not in the medical field. So if you use all kinds of medical jargon, it may be impossible for that person to grasp as to what you're actually telling them. You do not explain the treatment plan and follow-up care properly. You give limited advice to the patient. You do not tell them in detail. And you do not give time for the patient to express their thoughts and concerns. And like I told you, pediatric consultations are always an issue. You have to spend more time with the child, with the child's parents, and sometimes the grandparents also do come to the emergency department, and those are the ones who are actually very, very nervous and very agitated about their grandchild. So you have to spend more time, you have to be empathetic, you have to show them that you are caring for the child and not to worry and put them at ease. That's very, very important. What is the purpose of communication in the emergency department? This is not really about diagnosis. It is more about caring and sharing the information. And whatever communication or the information that you give should be clear, should be a complete sort of a communication. And whatever you tell them must be accurate. And tell them in a timely fashion. Suppose the patient is very breathless and needs to be intubated, you have to tell the patient's relatives, yes, this is the one that I'm going to do now. Or after that, the patient's blood pressure comes down, you may have to put a central line. That is the time for you to tell them that this patient requires another procedure. So tell them in a timely fashion rather than doing everything and then telling them. Then they would fight with you or tell you that you never told me all these things, doctor. I never knew that my patient was so sick and things like that. So always communicate to them in a timely fashion. And this should be verified by all the parties involved. call, because a patient now in our country, somebody comes into the emergency department, becomes a big social event. You have the parents coming in, or the uncles and the aunts, and there may be 4 or 5 people who are actually there with the patient, and 1 or 2 of them may be decision makers also. So it's very important that when you talk to the patients, attenders, or the relatives, it's better that you get them together, 3 or 4 people, and explain to them all at once rather than doing this repeatedly. Your communication skills basically are of 3 parts. Interacting with patients, about which we spoke to you earlier, and interacting with your colleagues and peers. That's very, very important. You should have a good working relationship with your colleagues and with your people who are working in your emergency department. In case you need consultations from other departments, you should be very clear and concise and precise about the patient's condition and why you require a consultation from them. That's the way to do it, so that they will understand that it's very important for them to come early and give their opinions. Interacting with other departments, like I told you earlier. This is another protocol that you can actually follow. It's called the SPIKES protocol. S is setting up the scene. P is the perception of the patient and relatives in a given situation. Invitation to disclose the problems. Sharing information. Empathize with them. And finally, strategize and summarize the whole thing. This is a good way of communication, but may be difficult in the emergency content, because you may have to spend more time with the patient's relatives explaining to them. But in a busy emergency department where your immediate patients are a lot, you may not be able to actually stop giving care and then communicate, because it's very important. Patient care is most important, and then only communication. So you need to strike a balance between these two. Like I told you earlier, provide information that is accurate, valid, empathetic, considerate, and should be very crisp. Should not be a distraction for the doctors and nurses from the vital clinical tasks that they must perform. So it's always patient care first and then communicate. So like I told you earlier, you need to strike a balance. The relatives have to be convinced that the treating team is doing its best, and definitely it would make a difference in the outcome of the patient. So if a patient is very breathless or hypotensing, came with diarrhea, BP is very low, you can always tell them, I'm giving fluids. The patient looks very dehydrated and he should get better with a couple of liters of fluid. So let us wait and see how he is. So you have to instill confidence both in the patient as well as the patient's relatives. Communication should be frequent and in short bursts. You don't have to tell them everything at a time. And always tell them on what has been done and what is currently going on. Suppose you have a patient who is breathless, like I told you earlier, you can always tell them that you have started the patient on oxygen and you started an IV line and giving them some fluids. And what is the next assessment that you're going to do? For example, the patient will need a chest X-ray, and after that would be awaiting a review by the pulmonologist. So if you give them this kind of information to the patient and to the relatives, they would know, yes, we are being taken care of in the emergency department, we are being investigated, and we are going to get our specialist referrals very soon, and the patient would be satisfied with the treatment that he or she is getting. This is another problem that can happen in our emergency departments, especially in teaching hospitals and medical college hospitals. You have your interns, you have your paramedics, you have your first year postgraduates, second year, third year postgraduates, junior consultant, senior consultant, postgraduates coming from other departments. And if so many people are actually going to examine one patient and keep asking the history again and again, the patient usually gets very agitated. So it's very important for the first person, the first doctor on contact, to get a proper history from the patient, write it down in the case sheet, so that the other people who come for referrals or the other doctors who come to see would actually see the first case sheet that's been written and just fill in the gaps and ask a few relevant questions pertaining to their specialty. A very busy emergency department, you probably have one consultant and a junior consultant and a postgraduate running a 30-bed emergency department with about 100 patients who come every day. So it's very difficult for one person to actually spend a lot of time or a longer time with every patient. And sometimes this leads to patients' dissatisfaction. Always listen to your patient. We spend very little time listening. Less than a minute we try to get a history, and when the patient starts talking more, we actually cut them off and tell them, okay, go on, or we ask the next question. Please be patient towards your patient. Always give them a good hearing. They would like to tell you the problems they had, and you may pick up something relevant from what they are actually saying. Please speak in a language which your patient can actually understand. Don't use medical jargon like earlier. If your patient does not understand English or needs to be spoken in the local language and you do not know it, get the help of an interpreter, so that if the patient is able to communicate in his or her local language, the rapport is much better. Like I told you, do not give them a complex diagnosis, which even I would not be able to actually pronounce whatever is written on this cartoon. So it's better that you break it down in simple words and actually tell them what the patient's problems are. Communicate effectively. This is one thing that actually everybody is on the cell phone all the time, and even when you look at a busy emergency department, you have your paramedics, you have your house surgeons, you have your junior doctors, and most of them are actually on their cell phones and laughing and talking. A sick patient who comes into your emergency department and you have the relatives and all, seeing all these things actually makes them very aggressive, and sometimes they feel very sad. What is this? We have come to your emergency department with so much of pain, and all you guys are doing is on your cell phones and talking, and you people are actually making fun. That's what they actually think. But you would have actually seen the patient and done whatever it is there for that patient, and the patient's actually feeling better. But when he sees all these things happening, he does not realize that, yes, I've been taken care of, but all these things would actually give a bad feedback for that particular department. Once upon a time, medicine was rather simple. And nowadays it's so complex. You have a doctor for every body part. But we as an emergency physician should be a jack of all trades. We should know the relevant problems that are there in all organ systems. We should be able to actually make a diagnosis of all life-threatening problems or even chronic problems. We should have the knowledge to come to a diagnosis, so that unnecessary consultations must definitely be avoided. You should have the courage, the conviction, the knowledge to take care of these common problems that the patients can come, other than life-threatening problems, so that you can dispose these patients much earlier, so that the time spent in the emergency department would be less. You should not be like this. You should not specialize in referrals. You should be able to take decisions on your own, and you should communicate that. For example, a patient comes with a loin pain and you think it's a urinary colic, and you do a CT KEB, you find that that's a calculus which is less than 5 mm in size. There's no point in getting urologist opinion and all kinds of things. You give good pain relief to the patient, discharge the patient, and ask them to follow up in the urology OP. You should have the knowledge to take such decisions. Use active listening. Always make sure that you listen to whatever the problems. Okay, you tell them that you understand, and you can see their point of view and things like that. Always empathize with the patient. Put yourself in the patient's position, and then say, if I had been a patient and I come like this, how should the doctor react? How should the doctor communicate? That is the way that you have to communicate. Always be humble. It's very important. The humbler you are, you can communicate better, so the patient feels comfortable with you. Use appropriate language, because there are people around you. The patient may be an older gentleman who's used to more respect and things like that. So always be using the appropriate language. Always stay aware and be thoughtful of what you say, and avoid offending people. That's very important. And always use I instead of we. If the patient is not communicating properly with you and you're a little agitated, always say that I feel frustrated, rather than you make me frustrated. So always use I. And these are some of the pointers that you can actually use for better communication in the emergency department. So what are the take-home points? Basically, ineffective communication, lack of understanding of disease leads to a disproportionate expectations by the family. If a patient is very, very sick, please tell the patient's relatives that the patient is extremely sick and these are the treatment options that you have, and always discuss that with them. before you actually do it. For example, it can be a terminally ill patient who comes into your emergency department, who is gasping, who needs intubation very soon. You can always tell them these are the options. The person is much older, and suppose the patient's relatives tell them, it's okay sir, you please give them palliative care, do not do anything that very aggressive. Always get that written from the patient's relatives so that you do not have any medical legal problems later on. Need for the implementation of teaching communication in our curriculum, that's very, very important. Always empower students with the desirable communication skills, and that's the only way to prepare them even when they are undergraduates, so that their communication skills as a postgraduate is much better. The National Medical Commission has made the Attitude, Ethics and Communication Skill modules as a mandatory part of UG learning, and I think that is the best way forward. I thank you for your patient hearing. I hope that you have all realized the importance of behavior, a proper behavior in the emergency department, and proper communication, which can lead to less amount of litigation for the doctor and reduce the incidence of violence against the doctors. Thank you again.